Good morning. I thought that I would kind of continue on this deep brain stimulation idea and ask, is it good for epilepsy? For those children who have both movement disorder and epilepsy in the setting of GNAO1, will one thing work for both? So before we get there, I just wanted to quickly review a paper that was just published, essentially the end of 2018, 2019, by the group at Children's Hospital Boston by Ann Podori. One of my junior colleagues, Erica Axine, was part of this author list and dug into some of the patient histories of those who had epilepsy. So I know the epilepsy data in here is very good because I trust Erica to have looked very carefully at all those patients. So what did we learn from this group in Boston? Well, they really published on 14 patients that they knew of, but then culled through the literature to pull out about 50 patients who have currently published in the literature and say, what can we learn from those 50 patients? And so what we learned is that of those patients currently published in the literature, about 64% of them have been described as having some form of epilepsy. And in the majority of cases, the epilepsy started prior to 2 years of age. That it was more likely that if we're going to have epilepsy with GNAO1, that you were going to have a developmental epileptic encephalopathy. What that means to me is that your seizures were very bad and started prior to 2 years of age. And in most cases, these children had infantile spasms. So of the 24 of 35 with epilepsy, 24 had infantile spasms, 7 had what we call focal seizures, and the remaining handful had both focal and generalized seizures. In that cohort of 55, about 50% had both epilepsy and movement disorders. And at the very bottom here, you can see Ann Podori's and her group's attempt to redraw what Dr. Newbig drew in that picture that Amy showed us, of trying to figure out, is there a genotype-phenotype correlation? Where do the variants sit if you're going to have epilepsy? Where do they sit if you're going to have both? Where do they sit if you're going to have epilepsy alone? And if we look at the, I guess that's purple markings there, you can see that if you're going to have epilepsy alone, your variant can be almost anywhere in the gene. And the yellow is epilepsy and movement disorders together, and again, it looks like anywhere in the gene. And then movement disorder alone, they do seem to be clustering in one place in the gene. So this is what the Boston group is teaching us about pathogenic variant location and eventual phenotype. So does DBS work in treatment of epilepsy? It certainly does. This is the pivotal trial that was published in 2010 called the Sante trial, Stimulation of the Anterior Nucleus of the Thalamus for Epilepsy. What they did was they took 110 adults, all with drug-resistant epilepsy, all who, some who had epilepsy surgery in the past, some who hadn't, but what was common was that they had all have failed at least 2 anti-seizure medications. And this is here their graph of seizure reduction in the placebo group, those who had a stimulator implanted but not turned on, and in the group who had stimulators implanted and eventually turned on. This is where the stimulator is turned on at about 1 month. And what's really interesting here is just undergoing the surgery. Both groups had a reduction in their seizures up to that 1 month period just from having the stimulator implanted. But you can then see after, when the stimulators are turned on, those groups start to diverge, whereas those in the placebo group no longer maintain this reduction in their seizure frequency, and those in the stimulator group turned on actually have about a 40% reduction in their seizures. That's great, that's out to 3 months, but we all want to know what happens at 2 years. And at 2 years, many of them retained the seizure reduction. So 54% maintained a 50% seizure reduction, and 14 of the patients were seizure-free. 2 years is great. What about 5 years? 5 years, now 68% had 50% seizure reduction. 16% were seizure-free, and almost all the patients had an improved quality of life. Reduced seizures, reduced quality of life for adults. Side effects, there were 5 deaths of the original 110. None were felt to be due to the implantation or the stimulation. There were some hemorrhages, minor hemorrhages at the time of implantation, but overall this was felt to be safe, and DBS is now approved for the treatment of epilepsy in those 18 years of age and older. What do we know about DBS for treatment of epilepsy in children? The data is quite limited. We have case reports and small series. Looking at how many patients have been reported in the literature who have children with epilepsy who have been treated with DBS, it amounts to about 40 patients. There's no one type of person. Some of them have epilepsy for one reason. Others in that 40 have epilepsy for other reasons. So of those 40, it's quite a heterogeneous etiology. Where did they place the stimulators? Well, they placed them in multiple places, and sometimes one side and sometimes both sides. So there are children who have had deep brain stimulation targeted to the centromedian nucleus of the thalamus, to the anterior thalamic nucleus, to the hippocampus, and to the subthalamic nucleus. So no one place among these 40 patients. So very heterogeneous placement of the DBS. So of that 40, 5 are seizure-free, so 12.5%, and 85% have had seizure reduction. Major side effect has been some staph infections at the site of the infection, but no major brain issues. So when should we consider DBS and other alternative therapies in the treatment of seizures? So we should start to think about other treatments for any child who's failed 2 medications, 2 anti-seizure medications that have been tried to maximum tolerated doses. So it's not like we tried topiramate, we gave a very small dose and decided we didn't like that decision. It's we tried topiramate, we got it up to a dose where we started to see side effects. That's a failed medication. So 2 failed medication. And then the important next question to ask is this person a candidate for resective epilepsy surgery? And the cartoon over there that I took from the University of Pittsburgh group kind of goes through all our thinkings of how do you decide if somebody is a candidate for epilepsy surgery? What keeps you from being a candidate for epilepsy surgery? One, you have a generalized epilepsy, so removing one part of the brain isn't going to get rid of your epilepsy. Or you do have a focal epilepsy, but it's in a part of the brain where if we removed, we know there will be major deficits. Or you have a focal epilepsy, but it's coming from 2 different places. Are all reasons that you wouldn't undergo epilepsy surgery. So in those cases, we need to think about other treatments. Often, many centers will think about ketogenic diet somewhere along the way, and then many of us will begin to think about responsive neurostimulation or deep brain stimulation or VNS. And why one or over the other depends really on the patient. What kind of epilepsy they have will determine whether we go to DBS, RNS, or VNS. So that was quick to keep us on time, but I wanted to thank those families, the Bells, the Foxes, who really started this group so that we could all be here today and doing the important work together to move our knowledge of GNAO1 along so that we can get to treatments hopefully someday better than DBS, better than anti-seizure medications, more specific to your children, and that we can be very proud of the work we've done and then have big parties just celebrating our victories. So thank you very much.